ATCM, the emergency medicine channel. Shall I start, sir?
Please.
A 29-year-old female patient presented to ER with complaints of recurrent episodes of nausea and severe vomiting for the past 1 year, and the last episode started 2-3 days back with diffuse abdominal discomfort. On initial 10-second assessment, airway is patent, no pooling of secretions. Breathing, respiratory rate is 18 per minute with saturation of 99%, and chest air entry is bilaterally equal. Circulation pulse rate is 102 per minute with BP of 170 millimeters of mercury, and CRT is less than 3 seconds.
How many times was she vomiting?
Daily around 5 to 6 episodes.
5 to 6 episodes, okay.
And disability is GCS is 15 by 15 with pupil equal and bilaterally reactive, and exposure is afebrile. At that point, we took adjuncts for primary survey, that is total count of 11,200. Mild leukocytosis is there with HB of 13.2 and platelet count of 310,000 and CRP is 4 milligram per day.
And what other parameter would be important here?
In this case, hematocrit
is important. What would that suggest of?
Dehydration and hemoconcentration.
Correlation? I mean, how will you correlate hematocrit to
with HB? HB into 3, thrice the HB value will be the hematocrit. Normal hematocrit.
All right.
And we also took VBG, which shows pH of 7.52, bicarb of 32, and PaCO2 of 44, and lactate is 1.2. Sodium is 133 and potassium 2.9 and chloride is 88.
What is this suggestive?
pH is a little bit higher side, which was suggestive of metabolic alkalosis. Bicarb is also 32 with the sodium 133, normal is 135, 136 above, and potassium is 2.9. So mild hyponatremia and hypokalemia picture is there, and chloride is also on the lower side.
Why is there metabolic alkalosis?
The patient has multiple episodes of vomiting and all. It will correlate with hypochloremia and hypokalemia and metabolic alkalosis.
Okay.
And we took one ECG also, which shows normal sinus rhythm.
Normal sinus rhythm.
We also check in the ECG for any sinus tachycardia because of the dehydration and stress. And also we have to look for if there is any metabolic abnormalities, there will be change in the QTC interval also.
QTC.
We also have to check if we take one ECG, but in this patient the ECG is normal.
What is a normal QTC in females?
450.
460?
460.
And in males it would be?
450.
440 around, yeah.
450.
So, electrolyte abnormalities and QTC correlation?
QTC will be prolonged in case of hypocalcemia, hypomagnesemia.
All right.
And coming to sample history, not allergic to any medications, no known comorbidities. A 28-year-old female patient with recurrent episodes of nausea of sudden onset followed by repetitive episodes of vomiting, around 6 to 8 episodes per day, and each episode is lasting for 2 to 4 days. That is for the past 1 year. That is for every 1 to 2 months. And the episodes will be associated with abdominal discomfort, dizziness, and marked fatigue. There is no specific aggravating factors, usually relieved by symptomatic management and completely asymptomatic in between the periods. And similar episodes is for the past 1 year with multiple hospital visits further, and for which she was evaluated, and the complete blood investigations, and also upper GI endoscopy was done, which was normal, and CT brain and MRI brain was done, also normal, and they also done urine toxicological screening, which was also negative. And there is no history of any fever associated with it, no history of any prior abdominal surgeries, no history of alcohol or drug abuse, and no history of chest pain or palpitation or headache associated with it. Her sleep pattern is regular, and it is usually disturbed during the work stress time. And diet is non-vegetarian, and menstrual cycles are regular, and there is no correlation with the menstrual cycles, these episodes. And coming to examination, there is no pallor, icterus, cyanosis, clubbing or lymphadenopathy. Perabdomen is soft, mild epigastric tenderness is there, but no mass, no scars or no guarding or rigidity. Bowel sounds present, and CNS neurological examination wise everything is normal, and chest air entry equal, and CVS S1 S2 heard with no murmurs. So in this point, we give one injection Pandocid 40 mg IV stat and also Emicid we give for mg IV stat. and also we give fluid resuscitation, and the patient get admitted under
What fluid did you give?
isotonic fluid, ringer lactate.
Ringer lactate. Patient has?
This metabolic alkalosis is there.
So what would you prefer here? Also you suggested something of hypochloremia is also there. No?
Hypochloremia. We can give NaCl. Sodium chloride
NaCl would be preferred here. You don't want to aggravate the metabolic alkalosis. Okay.
And after that, we admitted the patient under general medicine department for the complete evaluation.
Okay.
And when we come into the approach of nausea and vomiting.
All right. So, as you say, approach to nausea and vomiting is a very broad topic. You have a lot of conditions, differentials to look at. So, in this patient itself, she was very thoroughly evaluated. I would say they did a very good job evaluating the patient and coming up with a diagnosis, because this diagnosis, whatever she has, is a diagnosis of exclusion. You need to exclude all the other conditions to come up with diagnosis. So, let's look at what all are the differentials that you would be seeing in a patient with vomiting. What all are you, as an emergency physician, what all are the main complications of vomiting? What are you seeing? Yeah. What would we expect?
The differentials will be from the gastrointestinal neurological.
Let's start with the history taking. What are you going to ask this patient?
Okay, we will start with the onset and duration and frequency of vomiting, and we also ask for the timing. Is it early morning or postprandial? If it is an early morning, more correlation with pregnancy and also CNS causes will be early morning.
Okay.
And also in case of postprandial, it also related to the gastrointestinal causes. More possibly gastroparesis, gastrooutlet obstruction syndrome and all. And we also ask for the content of the vomitus. So it will determine the obstruction site, the location of the obstruction. And in a kind of esophageal diseases, the vomiting content will be the undigested food particles.
Right.
In case of gastric outlet, also food particles that is devoid of bile. But in case of small bowel, content is bile.
Content would be bile.
Right. And in case of large bowel, there will be fecal and material with a foul odor will be there.
Okay.
And also we have to ask for the associated symptoms like abdominal pain, the location and the quality of the pain, and also if there is any association with fever and loose stools, and in case of gastroenteritis. And we also have to ask for any sick contacts or ingestion of the suspicious food kind things,
materials,
and
yes.
also any history of recent weight loss. So that it will correlate to the malignancy, and also the psychiatric component also will be there in case of weight loss.
Very good.
And in CNS examination, we have to look for the in CNS symptoms, we have to ask for headache, visual loss, vertigo, neurological deficits or anything. And also has to ask for any past medical history, recurrent history of vomiting or the travel history. We also ask for prior abdominal surgeries, and that will lead to bowel obstruction or adhesions also. And we also ask for the medication list. These are the history-wise important things to ask. And in coming to the examination, we also have to look for the vital signs. If there is severe dehydration, there will be tachycardia, hypotension, and also look for the dehydration of skin turgor, mucous membrane, and also have to look for capillary refill.
Basically, you are trying to rule out the signs of dehydration. Right.
And in children and all, there will be significant dehydration. So there will be more than 5% loss of the body weight will be there. And the skin turgor, capillary refill, tears and all. And also look for the abdominal examination for the possible GI causes. We have to inspect, palpate and auscultate the bowel, and also the general conditions, generalized weakness, weight loss, and also any fever. And in case of intracranial hemorrhage or stroke, there will be hypertension associated with it. Otherwise, dehydration, there will be hypotension. And coming to the head and neck and eyes.
Hypertension and also some focal neurological deficits would be there.
Coming to head and neck and eyes, ear, nose, throat examination, there will be nystagmus in case of peripheral versus central cause of vomiting, and associated with dizziness. Exophthalmos in case of Graves' disease, and also in pinpoint pupils in case of any drug abuse and all. And also we have to look for fixed dilated pupil and eye pain that will be correlated with acute glaucoma. And dehydration symptoms. And in psychiatric condition like bulimia nervosa, there will be poor dental enamel, and also there will be parotid gland enlargement also will be there. And in case of abdominal examination, we have to look for any distension, decreased bowel sounds, or any surgical scars. And in case of hernia, there will be any palpable mass or there in abdominal rigidity in case of peritonitis. And neurological, mental status examination, cranial nerve findings, neurological defects, any papilledema, we have to examine. And also in case of bulimia, there will be scarring over the dorsal surface of the hands, extremities, because of the recurrent vomiting. They induce vomiting by hands. And in skin, we have to look for any icterus, jaundice and all, hepatobiliary causes, and also hyperpigmentation in case of Addison's disease, and decreased elasticity, and any skin tract markers in case of drug abuse and all. These are the physical examination most probably.
What if the patient has multiple episodes of retching followed by frank blood in the vomitus?
Bow syndrome, the tear in the
Malrive stage. Right, okay.
And when we proceed with imaging, we can do the complete blood investigations, basically complete blood count and the basic metabolic panel we can do with the liver function test and serum amylase and lipase if there is any signs of biliary obstruction or upper abdominal pain. And we can proceed with the pregnancy test if the woman is in the childbearing age. And also abdominal x-ray, we can proceed with ultrasound and CT. If there is any suspicion of intracranial mass or lesion, we also have to proceed with CT, MRI of brain. These are the basic investigations we have to rule out. And coming to the treatment, in emergency management, we always proceed with airway breathing circulation. So most probably in recurrent episodes of vomiting and all, most probably the circulation will be the thing. So we have to rehydrate the patient and it will give the symptomatic relief only. And for the vomiting, we have to give treatment like serotonin antagonists.
Right. So when we are dealing with vomiting, we should know about the complete neuromuscular and the pathway basically involved, because you're going to target each receptor involved in the vomiting, right? So if I can term it, I'll call it the central hub. This would primarily involve medullary and extramedullary pathways, but the main core of it would be located within the medulla, in and around the medulla, I would say. So the first one would be the chemoreceptor trigger zones, right? This is very strategically located outside the blood-brain barrier. Because it is located outside the blood-brain barrier, any irritant substance or poisons that has to be readily excreted from the body, would sensitize this trigger zone, and the patient would, eventually vomit it out. The second one would be the nucleus tractus solitarius, which would get a lot of afferent stimulus, from the glossopharyngeal nerve, the vagus, and also from the vestibular component as well. So the chemoreceptor trigger zone would have the receptors like 5-HT3, your serotonin receptors, and also the D2 dopamine receptors, and also the neurokinase 1 receptor. Remember the receptors, because we'll be discussing about the drugs as well. The second one, the nucleus tractus solitarius, would have your H1 histamine 1 receptors and also M1 muscarinic receptors. And then the other component involved would be the dorsal motor nucleus of the vagus, which would take the efferent impulses to the gut. And finally, you will have a component of the reticular formation. That is why instead of calling it a center, we would call it as a network. And this together would generate impulses that would trigger the vomiting. So as you rightly classified them into different systems and what would cause vomiting and what to look for, let me just put in a couple more words regarding the triggers usually that we see. The first one would be obviously the most common ones that I'm talking about in the ER, the gastric mucosal irritants or distension causing problems, like it can be acute food poisoning, it can be chemotherapy, radiation therapy, and it can also be, as you said, it can be gastroenteritis or enteritis itself that can cause the vomiting itself. So here, when you look at this, the main pathway that would include would be triggering the chemoreceptor trigger zone. So you have your 5-HT3 receptor antagonists and also the D2 receptor antagonists, right? So the second one would be the blood emetogenic agents that would be seen in the blood because of multiple conditions. The common conditions including uremia, sepsis, opioids, and also your any kind of poisonous substances in the blood. The third one would be your vestibular causes, like you have your motion sickness, labyrinthitis, BPPV, and all that. And then you'll have your very common biliary colic, renal colic, gag reflex induced vomiting, peritonitis, obstruction induced vomiting, and all that. And finally, you have your higher center, which can induce the vomiting. Higher center would include the corticolimbic system. Like you puke when you see some people puke when they see blood, or smell can induce vomiting, right? Also some stress can induce vomiting, and at the same time pressure, like that's why you do in this patient an MRI and CT was done, because that itself can compress the chemoreceptor trigger zone and can induce vomiting. So these are the common causes that can induce vomiting in patients. And also when we finished the afferent pathway, we found the central area where all this information is being relayed, and the decision to vomit is made. And then you have the efferent limb. In the efferent limb, it's very complex, but to sum it up, basically the patient, there will be the gut muscle contraction will be there, and the initial phase, the lower esophageal sphincter would be relaxed, and it would come up, and then the upper esophageal sphincter would remain contracted. And as the upper esophageal sphincter relaxes and the contents are coming in, you would see that there is a lot of saliva secretion. Saliva being alkaliniting agent, it would protect your teeth and mucosa from the acidic content of the bowel. And then your glottis closes so that the food particles does not aspirate into the airways. And then your soft palate arches even more further so that the contents do not go to your nasopharynx. It's a very beautiful process. But then symptomatically, when it look at it, it's not a very pleasantful experience. But now we should look at the drugs that are commonly involved. So you were saying the drugs, the D2 receptor antagonist. What would the D2 receptor antagonist be?
Ondansetron, granisetron, ondansetron and all.
Ondansetron, granisetron would be serotonin receptor antagonist. Yeah, D2 receptor antagonist would be metoclopramide. All that. So metoclopramide, ideally they have to, you have two advantages with this drug, and a disadvantage as well. But the advantage is that, one, it is a D2 receptor antagonist. At the same time, it is also basically the process of gastric emptying increases with this drug. So
prokinetic.
It's a prokinetic agent, right? And but the problem is, if infused immediately or suddenly, what happens? The patient will have an acute dystonic reaction. So you should know how to treat that. Extrapyramidal symptoms will also be there. So that is one class. The second would be your 5-HT3 receptor antagonist, which is your serotonin antagonist. That would include
granisetron, dolasetron, and ondansetron and tropisetron.
All these drugs. Now these are the first line agents in chemotherapy-induced vomiting. The first line agents, right? And move ahead. After that, we spoke about these two. Then you have your H1 receptor antagonist.
Dimenhydrinate and diphenhydramine.
Meclizine and all that, right?
That's also inhibit the vestibular stimulation and also anticholinergic effect.
Exactly. So this would help you in motion sickness and all your vestibular neuritis and all that. Induce vomiting. And then you have your M1 receptor antagonist, right? M1 receptor antagonist is basically a, before, in patients who have motion sickness, before the start of the journey, you apply a patch here, scopolamine, hyoscine patch, right? And you have your neurokinase 1 receptor antagonists. Those are aprepitant and fosaprepitant. These are delayed chemotherapy induced nausea and vomiting. You give this. If the patient has intractable vomiting after chemotherapy, you give your first line, second line, and combine it with steroids. This is how we normally manage chemotherapy-induced vomiting, because we get a lot of patients here. That's why I just stressed upon that. Any other agents, any other treatment that you would
There is also phenothiazines, that prochlorperamicin and promethazine in case of this migraine vertigo.
Right. That's a very famous drug, Stemetil. Why would you give that? What is this thing? It's a D2 receptor antagonist, and also it has mild H1 antagonist effect as well. So it can block all the problems, and vomiting is very well controlled. The symptoms are also controlled because of the the ear issue, whatever is the patient is suffering from, and also you target a higher center as well. Right.
And
Anything
also
else?
in case of urgent, you already said that severe case of chemotherapy-induced nausea, vomiting, we can give corticosteroids also.
Corticosteroids as well, right.
These
Let's
are the
if you could
treatment
talk a little bit about the
cyclic
vomiting syndrome. What is
That's
it?
usually seen in case of childhood more by the teenage years. So, and it's also more common in females than males, and
Males.
higher incidence if the patient is taking opioid and tobacco abuse is there. And the predisposing cause is unknown, but there is a mitochondrial DNA mutation. The studies are going on related that, and the dysregulation of the neuroendocrinal system. It is basically there is a criteria, Rome for diagnostic criteria for this. There will
Most commonly, it is seen associated with individuals suffering from migraine.
migraine also.
Migraine.
So it's
All right.
migraine and abnormal vagal tone.
Abnormal vagal
So
tone.
that the patient presented with lethargy, anorexia, pallor, abdominal pain, and autonomic symptoms like sweating and salivation. And it's also associated with migraine. The prodrome will be there, nausea, vomiting, photophobia, and it will be separated by the symptom-free period. That is
Symptom-free
included
period.
in
That is very important.
Included in the diagnostic criteria.
Criteria.
That is more than or equal to 2 stereotypical episodes of vomiting in past 6 months, and there will be symptom-free intervals between the episodes, and there will be no evidence of structural, metabolic, or CNS disease.
CNS also.
That is
Ruling out others.
ruling out the other options. And mostly the diagnosis is clinical and diagnosis of exclusion. There will be history of multiple ED visits and hospitalization will be
Same
there.
complaint.
And the comorbid conditions like anxiety, depression, irritable bowel syndrome will be there.
Migraine and all
And the
will be
4 phases are there: asymptomatic, prodrome phase, hyperemesis phase, and recovery phase. Asymptomatic period is for the several many months, and in prodrome phase will be lasted for minutes to hours. That the patient will experience lethargy, photophobia, anorexia, sweating, and salivation, and it will proceed to hyperemesis phase. That is usually starts in the morning, and it will proceed to days to weeks. And recovery phase is improvement in the symptoms and the energy levels. So in this time, we will manage the patients. If the patient presented to the ED in acute condition, we will manage it with antiemetics, fluids, hydration, and all. And if there is any abdominal pain, discomfort, we will provide analgesics and all. If there is recurrent vomiting episodes and if it is refractory, we will also give sedatives to the patient.
Okay.
Benzodiazepines and all. And the prophylaxis will be avoid the triggers. And if there is any sleep deprivation and anything, we have to correct it. And diet and physical and emotional stress
should be
can
avoided. Basically, a lot of lifestyle modifications will
have
help
to
the
be there.
patient.
Avoid the caffeine, alcohol, and chocolate. And also we can try for amitriptyline that also have good response rate. With the migraine prophylaxis also we can try with the sumatriptan, propranolol, and topiramate. And also nowadays mitochondrial targeted therapies are also there with L-carnitine and coenzyme
Q10.
That can be given alone or in combination with amitriptyline.
Amitriptyline. So mainstay of treatment would be amitriptyline, prophylaxis of migraine, propranolol, amitriptyline again, and then you can
Lifestyle modifications
and all that. And then if at all mitochondrial involvement, if you're suspecting, you can give coenzyme Q10. I mean, it's not going to create any harm.
And most probably we admit the patient if there is any significant underlying disease or there is an unclear diagnosis, we mostly admit the patient and evaluate.
Right.
And if the patient is poorly responding to the fluid and antiemetic therapy. And in case of extreme ages also we will admit the patient.
Admit the patient.